Thank you, Professor Lehmann, for an introduction. And dear colleagues, yes. I'm a member of Christian's team from Basel, and I'm happy to present the results of the study, Do Heart Events Lead to Better Lipid Control versus Procedures? So as we all know, the management of dyslipidemia is one of the cornerstones of cardiovascular risk reduction. And low-density lipoprotein cholesterol, or LDL-C, is a well-established causal risk factor for coronary artery disease and stroke, and it's also the primary therapy target. The guidelines, the European guidelines, they define very strict same goals for all patients in secondary prevention. However, as a consequence of more intensive secondary prevention programs that follow acute heart events such as acute myocardial infarction and stroke, the lipid control in patients that only have a coronary revascularization procedure in the past medical history could be suboptimal. However, this difference between those two groups of patients have not been well investigated. I'll now turn to the future aspects of dyslipidemia management, and that is the lipoprotein A. It's also a risk factor for development of atherosclerosis, and it's a potential therapeutic target for further reduction of residual cardiovascular risk. But compared to LDL, the target values have not been well determined, and also there's no evidence that selective lipoprotein A lowering therapy brings any benefit. Structurally, it is very similar to LDL, so it possesses an atherogenic effect. But apart from that, it's believed to have some pro-inflammatory and pro-thrombotic properties, which could potentially provoke plaque rupture and thus occurrence of a heart event. So this leads me to the aims of the study is first to compare the LDL levels of patients with history of heart event versus history of procedures, and to test the hypothesis that lipoprotein A is elevated in patients with a history of heart event compared to patients with only history of procedures, and that is in view of the prothrombotic and pro-inflammatory characteristics. And lastly, to investigate the impact of these two atherogenic lipoproteins on the major adverse cardiovascular events. So this was a prospective single-center observational study that was performed at the University Hospital of Basel, and it was designed to evaluate diagnostic and prognostic value of a lot of biomarkers for functional coronary artery disease. And we enrolled patients consecutively that were referred for myocardial perfusion scintigraphy, and they were divided into three groups, so heart events, only coronary revascularization procedures, and non-CAD and stroke, but with cardiovascular risk factors. We performed follow-up after 1, 2, and 5 years, and the primary composite outcome consisted of acute myocardial infarction, cardiovascular death, and stroke. We enrolled in total 4,090 patients with baseline lipid measurements between 2010 and 2016. And a short overview of their baseline characteristics, we can observe that the population was predominantly male and also old, relatively old, with a median age of 68. And what is important is that the statin usage in the patients with heart event and patients with only coronary revascularization procedures were comparable, around 82%. So at baseline, we found that LDL levels in patients with a history of heart event was significantly lower compared to patients with history of only coronary revascularization. And furthermore, the adherence to the current guidelines to the at the time point of enrollment was significantly higher in the patient group with history of heart event. And at the time, the recommended value was 1.8 millimole per liter, which is represented with this horizontal dashed line. So as for lipoprotein A, we detected no difference between patients with heart event versus procedures. However, we found that the patients with known CAD and stroke had significantly lower values. And of note, the inclusion threshold for ongoing phase 3 clinical trial that tested the selective lipoprotein lowering therapy corresponds to the 19th percentile of our cohort. So we were able to achieve a very good follow-up rate of more than 95%, and we observed primary outcome events in around 15% of patients, with the highest incidence in patients with the history of heart event. And in this multivariable adjusted survivor curve, we can see that the LDL has not shown to be an independent risk predictor of composite MACE outcome overall. In this graph, the LDL was stratified by quartiles. Furthermore, we didn't observe any difference between the group. As for lipoprotein A, in the Kaplan-Meier analysis, patient groups that were stratified by lipoprotein A had approximately similar incidence of MACE. And in particular, patients with extremely elevated lipoprotein A did not appear to be at higher risk of MACE. That was also confirmed in the Cox regression analysis with multivariable adjustment. However, interestingly, in patients without statin therapy at baseline, we found that lipoprotein A could have a modest prognostic value with multivariable hazard ratio of 1.12, and this is the effect of doubling the lipoprotein A. So I'll mention some limitations of the study. First of all, this was a single-center study, so we should test this in a multi-center setting. Second, only baseline LDL measurements were available, so we didn't account for possible statin initiation and the follow-up time. And to conclude, history of heart events was associated with better lipid control. Lipoprotein A was not elevated in patients with a history of heart event compared to only procedures. And LDL was not shown to be a good predictor of MACE, and lipoprotein A was a modest predictor of MACE in patients without statin therapy. So thank you for your attention, and I'm ready to take your questions.
Thank you for your excellent presentation. Now we invite questions from the floor.
Thank you, Klara. Very nice presentation. Why do you think that the group with the highest lipoprotein A don't have a higher risk for MACE? Do you have a theory about that?
No. We don't have, actually, this was only at 19% of our population, so maybe it's not enough number of patients that comprise that group. And also these patients, when we look at the baseline characteristics of the patients, they have a higher statin usage compared to other patients, so maybe that's made a difference, but at the end we don't know.
But you do have an idea?
I have an idea.
Thank you.
Very interesting data. Do you want to jump in?
No, did you consider that a heart event is not necessarily correlates with extension of atherosclerosis, because sometimes you can have a higher degree of atherosclerosis in patients without any heart event. And this could be disturbing when you consider the prediction of these biomarkers, lipoprotein or A or LDL, different.
I'm not sure if I understood the question.
To have a heart event is not really an expression of extension of atherosclerosis. Do you consider this?
We just look what is the lipid control between patients. We didn't go into what is the pathomechanism of these heart events. What we suppose that the patient care for patients with a heart event is better. So this was the main idea for this analysis.
Yeah, interesting data. I wouldn't be too disheartened by the prognostic data. Statins obviously are the major confounder, with statins increasing Lp(a) and decreasing LDL cholesterol, which is almost certainly making it very difficult to see a true relationship between the biomarker and events. And my question is, did you consider adjusting for statin use and statin intensity in that model to see whether that would reveal the true underlying relationship probably between the biomarkers and events?
Unfortunately, we didn't have this information, what is the dosage of statin, but that would be certainly important to look at, yes.
And I thought at the heart of this project was quite an important question, which is, does the presentation, whether it's with an acute life-threatening event or just coming up for a procedure which cardiologists love to do, impact on either adherence to preventative therapies or lifestyle measures? And to that end, have you looked at broader lifestyle measures to determine whether smoking rates are lower in those with heart events, or activity levels or weight were lower? Did any other important prognostic risk factors differ between the two groups?
Yes, that would be also be interesting to see. However, we didn't have this data about smoking habits after those events and other lifestyle factors.
Yeah, thank you.